Hello. Good afternoon. We are going to go directly to the subject because it is long. It's just loading up. Okay. That's troubleshooting. What we're going to talk about, the patient who is cardiac confusing, the post-angina and MI patient on aspirin, post-CABG, pacemaker, rheumatic history, hypertension, up to here is cardiology, diabetes, hyperthyroidism, and pregnancy. These are factors which can bother you at the dental clinic. This will be the first part of the session, pre-lunch. And that will be followed by steroid, asthma COPD, renal compromise, dialysis patient, liver tissue and jaundice, epileptic patient, allergy. So that's all. I think all the medical topics that we need in dental practice have been covered there. It will be good to have notes because there are values and figures which are medico-legally important. So we are going into this funny concept of cardiac confusing. The patient comes into the clinic and there is this worry that this patient complains of some underlying cardiac condition which you are not very sure about, and you get confused and start referring and start beating around the bush with the patient. That is a pretty common practice. There is nothing called cardiac confusing. If you have a clear history, past and present prescriptions, you know the medications, you narrow down and pinpoint what is the cardiac problem of this patient. Don't believe in this word called ki jano eta cardiac paper ache. I've seen. I'm talking from prescriptions that I get. I get to handle these patients, and I see that the concept of very clear idea about what is happening with the heart is often not present. If you don't have the time to find out all those, you're really busy then, and you do not need this one extra patient. If you don't have the time to really find out what is going on with the heart, consult and discuss with cardiologists, and please make sound referrals. In a patient who is a kind of just about on aspirin or things, and you send the patient straight away for cardiology opinion before doing the root canal treatment, what it proves is, please do not refer to announce the dentists are medical illiterates. That's insulting for some of us. Do not do that. It's no good practice. It doesn't lift your position in the face of the patient either. What are the usual issues? Cardiac confusing is gone. So now you know exactly what is going on. The first and the commonest is post-PTCA, that is the patient who has got a chest pain, actually had a percutaneous balloon angioplasty, stent placement, or had a myocardial infarction. Usually we have these placements after myocardial infarctions, mild or unknown as well. We know what angina and myocardial infarction are. There is a supply-demand crisis. The supply is reduced due to atherosclerosis and narrowing of the vessels. So the amount of oxygen that is needed for the heart muscles to perform perfectly, which is a very busy muscle till the last breath of life, and it does require a lot of oxygen, and that is supplied by the blood. If the blood supply is reduced for any reason, the muscle will cry, and that is the pain. And if it is reduced to a significant level, part of the muscle will die, and that is myocardial infarction. So ischemic pain or actual ischemic damage happens due to problems like supply demand. Exercise, anxiety, pain, cold and lying flat are factors which increase the demand of the heart muscles for more oxygen. Why it is important for dentists? Because yes, we do not make the patient exercise much, but we give them anxiety, we give them pain. All the chambers are air conditioned nowadays, and it is the time of lying down dentistry. We don't do it over the surgeons. We have to manage it standing, but it's the time of supine dentistry. So all the other factors, anxiety, pain, cold and lying flat are there. So we do increase oxygen demand, and that's why we are more prone to getting a patient to start having a chest pain than in many other specialists. All those factors. What we need to do, we need to predict who is at a higher risk of cardiac condition. You check those. I will not spend a lot of time because this also goes under the emergency management. Look at the biggest points and just know that if this patient is a smoker, obese, has got an underlying condition like diabetes, kidney issues, cholesterol, and there is hypertension, primarily these are the two, then this patient is probably at higher risk. And and there is a history of a relative dying below the age of 50 due to obvious cardiac reasons. This gives you the profile of a patient who may be a mild cardiac risk. So there's nothing to be scared. There's actually nothing to be scared in medicine. It is all about being careful. Be careful with this kind of a patient. Know in detail the medical, specifically cardiac history. How can we prevent? Preferably no procedure within 6 months of a known myocardial infarction, unless you are pretty well trained in management of cardiac emergencies, unless you have got a hospital facility along with you. Avoid the patients within the first 6 months of myocardial infarction or a surgery or a treatment for myocardial infarction. They mean the same actually. If a patient had a myocardial infarction and had a PTCA, then you don't operate within 6 months of PTCA. If you have a bypass, don't operate within the first 6 months of bypass. Things can go pear-shaped and you may not have a very clear reasoning why it happened. There comes a very important point. Do not stop aspirin, and that is official, and nowadays it is very easy to find in by Googling. Go to Google for the international cardiac bodies and dental bodies, the international ones preferably, and you will find it very clearly what is mentioned there. That is the dictum, do not stop aspirin. Prophylactic GTN spray for people who need GTN spray. There are people who will be carrying their GTN spray or give a history of regular use for chest pain. These patients should get a GTN spray before dental treatment. Know one thing, GTN is not for patients who drop their blood pressure too much. This is a potent vasodilator. So if you give GTN spray to somebody who is not exposed to it, somebody who fluctuates very much, has a very low diastolic pressure from time to time, definitely not for them, because the patient can actually die of hypertension due to the use of GTN. So you just know who to use GTN. Preferably not a supine dentistry for them. You relax yourself, otherwise the patient gets more anxious. Reassure the patient, sometimes mild anxiolytic on the night before. If there is history of recent MI, consider referrals. By and large, no issues except consideration of antiplatelets. All the rest of the things are well manageable at the history level, and you know who to treat and how to treat. So I think that is pretty simple. The cardiac patient, in relation to ischemia of cardiac muscles, is not a major concern, apart from the factor of antiplatelets, which we will discuss further. Just for additional information, what happens and what to be done if there is an acute chest pain in the middle of your treatment or at the beginning or in the waiting area. Know what this pain is like. Severe crushing retrosternal pain is the pain of myocardial infarction or cardiac ischemia. It will usually always have radiation. Now, of the first two, you have to believe the patient. Signs are very important. You will actually see pallor and sweating in these patients. That is where you start getting concerned. This is a factor. The autonomic nervous system comes into play. When something real happens to a person, the autonomic nervous system will give away the clues. There will be dilated pupil. If the patient has got pallor, sweating, dilated pupil, and is also complaining of chest pain and breathlessness, this patient is getting a cardiac condition. So your stand, like when you are batting against different types of bowlers, your stance changes. Now your stance gets pretty serious if all these things come together. Other things that can come is nausea, actual vomiting. This will be followed by loss of consciousness, weak irregular pulse. Okay, now the shock has set in. Weak irregular pulse in this unconscious patient who was feeling breathless, had a chest pain, is now in a cardiogenic shock. This patient is a situation of life saving now. Whatever, I'm not trying to scare at all. That is the most important thing. There's nothing to be scared. What you have to do at this stage, now leaving aside the hypertension, because that is the last stage. We're talking about the initial stage. GTM goes in for about 3 minutes. You can check and ask for help. That is extremely important. You must. Do not lie this patient flat. Oxygen, nitrous oxide, 150 to 300 milligram, preferably chewable aspirin. You should have it available and get ready for CPR. So you know what CPR is. You better also get trained at the earliest opportunity in good quality CPR. Have the number of an ambulance and emergency room visibly somewhere in the clinic, in the waiting area. Almost all the people linked to the clinic on a regular basis should have this number available. This is what is going to save you eventually. Now, if you are talking about cardiac conditions and if you are kind of brave enough to take serious cardiac patients also for small minor dental issues, you should rather know a center with a cath lab and round-the-clock interventional cardiologist, because if something is going to really change the situation, not only save life but also save muscle, that's what the terminology is nowadays, cardiac muscle. It is called primary angioplasty, and that can only happen in a center with a running cath lab which is open all the time with suitable specialists. So know such a center nearby, have the number available. These are more important than the whole of the rest of the knowledge before. What must you do? Be able to identify who is at risk, as we discussed just now. There are many patients who are just a little bit more precious. They like a little more attention, and that's why they talk of pain everywhere. But they cannot modify their autonomic nervous system. So you know the autonomic nervous system symptoms, signs rather, and you know who is at risk. Beforehand, even before starting the patient at the level of history, you know who is at risk. And as we discussed about what are the features, you know when it is going wrong. You should be able to hold your own now, be able to provide CPR, have oxygen available if possible. That is something which is not available in almost any dental clinic usually, but it doesn't take much, neither financially nor arrangement-wise, to keep one small oxygen cylinder available somewhere. Have GTM spray or tablets handy and call for help in time. Just that much. It will help seriously if you have a proper life support certification or life support card. These are my cards which are valid till July 2021, when I will have to go and get recertified. If you have an advanced life support provider card and everything has happened and God forbid things have gone really bad, well, under certain circumstances, if there is nothing else to be done, and you can actually provide an ACLS provider card, you are reasonably medico-legally safe because you are considered the best person to be able to provide the advanced cardiac life support on the spot. Okay, so think about it. It's easy. It's a 3-day thing. Doesn't cost much to get a certification for 2 years. It really helps in time. So we have finished the ischemic cardiac situation and managing the patient. In the patient who has got a reduced cardiac oxygen supply, gets pain from time to time, is a little bit hypertensive, has got some systemic conditions, and a patient who has got a chest pain at the time. So under these kind of circumstances, I think we have covered it all. We are moving on to the next point, which these patients also get. These patients are either on aspirin, clopidogrel, or an anticoagulant. There is a significant difference between these. The first two are antiplatelets and the last one is an anticoagulant. They are not the same, and their management are very different. So these are the three things which you will have to. There are many new drugs which have now replaced warfarin, but they work in the same principle. Like clopidogrel is the newer one which has left 100 years of aspirin behind now. Okay, when you are concerned about a patient's bleeding risk, what are the tests to send? You send for PT, PT, INR, APTT, platelet count, and hemoglobin person. Now, PT we all know. Normal practice is BT CT. CT is made obsolete internationally because it is a subjective test. Somebody breaks glass capillaries and decides when it is getting stringy. It is somebody's perception. In modern medicine, somebody's perception has got no footage. So CT is internationally obsolete. It will look nice, you will look smarter medically if your prescription has BT and then jump to PT and skip CT. Just know that APTT, this is a rough, easy number to remember. It's about 30 seconds because we all know about INR. You do not have to remember the perfect PT because Whether the PT is good or bad, you will know by INR, and we all know that INR, the magic value is 1, which is a pure number, it's a ratio, so it's a pure number. So, we forget about what is the real value of PT, because you look at the INR, and if the patient is far away from 1, then there is a problem. But remember about APGT, because there are patients who will bleed, but has got a reasonably good INR, and those are the patients who have got a raised APGT. The standard value for APGT is about 30 seconds. Some say 31, some 37. There are plenty of values. Easy to remember is about 30 seconds. Don't be very comfortable if the patient is far away from 30 seconds. You need to know the platelet count. Well, if you have a bad APGT, platelet count will probably have a problem there. And better to know hemoglobin because you are likely to make this patient bleed. So don't start taking even a simple dose if a patient is 7.5 in hemoglobin and has got a dodgy area there, but don't be scared at 9. These are very subtle values. Just for information, the official medical legal requirement for blood transfusion is 7.5. So 7.5 and below is serious. Preferably you do not touch them because these are patients who are almost suitable for blood transfusion. You know that around 10-ish everything is fine. But you have your judgment about the procedure work magnitude and your capabilities and your handling abilities in terms of infrastructure in the zone between 7.5 to about 10. At 10 on, everyone is fine. So that is the small zone you have to be marginally careful about. So that's why you need to know the hemoglobin. I have already talked about antiplatelets and anticoagulants. Do it up, it helps. Up to 100 milligram aspirin daily, this is the official statement, this is the official dictum, and that is the page and the line mentioned there. Up to 100 milligram aspirin daily, there is no need to interfere in case of 1 to 3 teeth extraction. And that is medical problems in dentistry, teeth lesions, Kali and Gaussen, page 151. That is actually pure material even for the court and also for the very smart patient relatives. You can have that page photocopy kept somewhere because they sometimes come and command you that the patient is on aspirin, why don't you stop? My cardiologist says so you better have that handy. Know how it works, how long it works, how long it takes for it to work. Say for example, warfarin takes about 2 days to start working properly, start changing the values. So just starting the warfarin immediately after a procedure is not a problem. The patient will not start bleeding immediately. 48 hours will be good enough for the primary clot to be stabilized, and by the time it is stabilized only, warfarin will start working. Now remember about clopidogrel. Clopidogrel does not only change the platelet properties, it has got other factors, other things working on the vessel lining and the platelet aggregation issue. So, clopidogrel is a little bit unpredictable. So the technique is what you do, you convert the patient, feel free to consult and involve your cardiologist in this business. But what actually should be done is, you stop the clopidogrel, change the patient to aspirin because that is a predictable medicine. And that medicine has been used for 100 years. We exactly know how it works. Before clopidogrel was not there, so before that aspirin was the only one. So we shift this patient to aspirin and we treat in the way that aspirin has to be handled. That is, at the most stop 4 days in advance, but up to 100 milligrams of aspirin do not require to be modulated for 1 to 3 teeth extraction. I think that is clear and that is legal. Operating range, INR is 2.5 to 4. That is very interesting, 2.5 to 4. And that is the page number. It is in 2 places. In Medical Problems in Dentistry and British Journal of Oral and Maxillofacial Surgery, 2000 March, page 124. INR 2.5 is for a dental surgeon, INR 4 is for oral and maxillofacial surgeon. That is the maximum range. Now, there is a very important point. Nobody is supposed to be in INR 4. 2.5, 2.6, 2.8 INR is good enough for anything and everything to do with the heart. So, if things can wait, send this patient back to the cardiologist, stating clearly, don't state whether I can extract a tooth. State his INR needs to be within a reasonable range of therapeutic importance. An INR of 4 has got the only therapeutic importance of making the patient bleed in the stomach. Heparinization, you want to know what exactly how it works because most of you will not need to do it. Get the hematologist, get the cardiologist, take the cognizance. You don't need to be bothered because people don't understand your good intentions mostly. However, I'm just telling you, it's a very simple thing. Heparin is one of the shortest acting anticoagulant agent. So it takes about it stays there in an active way for about 6 hours only. Whereas warfarin stays for days. Now this patient is on warfarin and patient has got a poor INR. In that circumstance, you have to do a procedure, perform a procedure which has got a high risk of bleeding. What the patient gets done is the warfarin continues where heparin is started. Then warfarin is stopped. Warfarin can be stopped even for 2 days before starting heparin. As we mentioned before, that warfarin stays in active condition for at least 2 days, if not more. So stop warfarin, put the patient on heparin, hospitalize the patient preferably. And you keep checking the INR and APTT. What happens is you will see that INR reduces whereas APTT remains same or increases even. Because heparin works on that route. Under such circumstance comes a time when the INR is very comfortable, below 2.5. You take the patient for the procedure, you apply all the local measures, but when you do the procedure? About 6 hours after the dosage of heparin. That means the heparin has now worn off. The patient will coagulate in reasonable time, probably. Because in medicine, there is nothing called never, nothing called always. There is always a range. So probably definitely it will be better than not doing anything. So you perform the procedure 6 hours after heparinization. So this patient is now in a coagulable status. Then you start the patient on warfarin and continue heparin. About 6 hours to 8 hours to 12 hours later, you give the heparin dose and you start warfarin. In a few days, you will see that the INR is rising and you will cease the heparin gradually. That is the heparinization protocol for a poor INR patient on whom some procedure needs to be done in the oral cavity. Now we are passing the patient through a hypercoagulable state. So what's the big deal? The big deal is we are reducing the window of danger to 6 hours. Okay, which would have otherwise been many days. We are now bringing the patient to a status where the window of risk is very small. There will be discussion about special techniques in these patients, and there was a time when Dr. Blot and plenty of other medicines were there in practice, which even had elements which were not regulars of modern medicine. Anything that promotes clotting used to be used. Things were soaked in gauze and all, locally applied, some injections were there. But today, we still prefer to stick to some modern medicine. So, tranexamic acid has got very clear role. The great role of tranexamic acid is that it doesn't do much inside the vessel because it is a clot destabilization preventing agent. Once you remember the coagulation cascade, you will know that the coagulation cascade is completed by clot dissolution. It is not completed at clot formation. Tranexamic acid prevents clot dissolution. So, because inside the vessel clot is not supposed to form, therefore, inside the vessel tranexamic acid is not supposed to have a role at all. So, the tranexamic acid will only help you in the part which you don't want. That is, in the part the part of the bleeding that you don't want, that part will be prevented by tranexamic acid. So it is a great friend of ours. It can be used systemically as well as locally. However, there are debates and there are confusions, and we still prefer not to use systemic tranexamic acid in patients who are in significant cardiac risk. We use local for everyone and systemic only for people who do not have an additional cardiac component. It is more from the point of, just as I said, there are areas which are grey. Because nothing works like perfect. Yes, it will not do anything inside the vessel. It's not like that. It is not supposed to do anything inside the vessel. Okay, I think that's not too confusing. Vitamin K is primarily to reverse the warfarin situations where things are going out of hand for warfarinization. In such circumstances, vitamin K comes into action. There are other medicines that mess up hemostasis and there are other conditions that mess up hemostasis which will be covered in short. First, about the special techniques. Knowledge and preparation as well as informed consent. That's the most important special technique in a patient who could bleed more than others. You need to make it clear in few lines that you understand that this patient can bleed more. That is actually fantastic in court of law. That is another that ignorance is not acceptable in a qualified person. That is the problem. You need to make sure that you have documented the fact that you understand this patient has got a higher bleeding risk and what precautions have you taken. You have got a piece of surgical, kept it somewhere, or you have got suture system ready, etc., etc. Simple things. And you have, okay, let us move on. Avoid unnecessary extractions. These are the cases who can bleed a lot. These are the best cases for doing RCTs, which are kind of like, which should not be done otherwise, like RCTs of AIDS. I know many people do, but I'm not talking about a bridge situation. But just like that, you get rid of it. You don't do an RCT, but an RCT pays more. You prefer not to do it on other patients, but this is the ideal candidate. Here you go for all sorts of things to preserve even the remaining 1/3 of a root. You have got all logics in favor of you. You don't want the extraction. Do a root canal, do a coping, do all that, preserve the root, don't take it out. That also applies for patients who are at risk for enlarge or ORN, that is osteoradionecrosis. This is the interesting part. Planned surgical is always better than extraction with a lot of digging. Because when you do a planned surgical, you reflect the flap and you get end-to-end closure, which is not available in a standard forceps extraction. Obviously, not a planned surgical for a mobile anterior, but in cases where it might be a little bit of a struggle, go for a planned surgical rather than a general Coupland's extraction. This is the same thing. Pressure for a length of time, 5 to 10 minutes at the most. Pressure will stop as we say in the operating theatre when it starts bleeding and we get pretty frustrated. There is one thing that we have to remember always, pressure even stops the bleeding from aorta. So remember, pressure is fantastic and it will give you the primary clot in most cases. Even in hemophiliacs, but the pressure will have to be for 10 days. That's a different story. We'll talk about that separately. These are a few things which can be used and should be used pretty generously in patients with high risk of bleeding. We talked about tranexamic acid. Remember about temperature. We say all patients to avoid warm. Now, what is warm and what is hot and what is the vaccine? When a surgeon opens up the abdomen and does a big surgery, he or she asks for hot mops. How can it be? Hot mops control bleeding and the warm things will give rise to more bleeding somewhere. It doesn't work that way. It's at about 60 degrees centigrade temperature, the enzymatic activities of the coagulation cascade becomes the best. So, a gentle warm thing is often helpful in certain bleeding circumstances. But beyond that, we are calling for a hyperemia due to temperature, which will knock off the small clots and make it bleed. So that is the zone. And cold always will cause vasoconstriction. So if you go for some ice packs and such stuff in small bleeders, capillaries, they will just collapse and go in favor of you. A scarred area and an inflamed area will bleed more. So if you can if you have a chance, try to control all inflammation before going for intervention. The bun and the splint are fantastic friends. As we discussed, even in hemophilia, I have been the maxillofacial surgeon for Calcutta Medical College, and Calcutta Medical College having the biggest hemophilia unit in the city. I have to regularly handle patients and whom no one is going to touch for extractions. I don't do the extractions, but I organize everything so that everything goes smooth. All you do is take an impression, make a splint like those bleaching trays, and you remove the tooth which you are going to extract from the model, and now you pour the splint to the extraction and put some surgical into the socket of that area and you can cement the splint onto the teeth. So you cannot hold the pack for 10 days, but you can, the splint can hold it. So these are very simple things, but are lifesavers. That I have just mentioned because what happens if everything fails? We can open the neck and control the external carotid. takes about 15 minutes, can be done under local anesthesia. It's no big deal, but obviously that requires training and experience. And that's another side, that's another lecture. Anybody, I would love to meet people in those lectures as well, because we oral surgeons need much bigger teams. We are very few, we are being pushed. Okay, I will tell something now. I will bring these kind of plenty of slides. Don't get scared, don't look at the slides. These are the main pages on the basis of which these slides are prepared. What you need to know is the part that we have kept in writing on separately. I've kept these again for medical legal purpose. What is the basis of my talking? That's why these main slides are there. This is about drugs that increase bleeding risk. What it boils down to is, obviously we have covered anticoagulants and antiplatelets. That's why I have wiped off that first bracket. Remember about NOS, NSAIDs, SNRIs and SSRIs. So these are the SNRIs and SSRIs are psychiatric medicines usually mostly used as antidepressants and all. A non-steroidal anti-inflammatory agents are, we all know what they are. And this group, ANOAs, are the modern versions that goes from the direction of clopidogrel and all. So it can come under the first wiped out area. So these are the only 4 things that you have to be concerned about a little. Other conditions that mess up hemostasis are conditions to do it. First we have covered the cardiac and all those conditions because we have already covered them. Liver, kidney and bone marrow conditions are conditions which you have to be careful about because these are situations that will interfere with coagulation. So when you take the primary history and you get a note about liver, kidney or bone marrow, remember that you have to be careful. There are many congenital disorders which are all together called coagulopathies. I have given the names of you all know the names, but again, this is not a oral pathology classroom or medicine classroom, so you don't have to remember everything. Just know that if the patient complains of a coagulopathy, something like platelet disorder, von Willebrand disease, hemophilias of the different types, etc., the factor disorders, it's a confusing topic. But the patient has got a coagulopathy, full stop, that's all. You can pack them up in one club. And these are the situations. Liver, kidney, bone marrow and coagulopathies. Apart from the drug-induced ones, you don't do things in a very casual way. You get specially prepared or just pass the buck. There are people who are just waiting there. Don't waste your time, waste your day for these things because it doesn't pay. I'm not talking about money. It doesn't pay even in view of patient acknowledgement that you have been trying hard to help them out. Today the media and the system has worked in such a way that they are just thinking that you get up in the morning and go out and sit on the chair to earn some money out of them. So they will not appreciate your special efforts to help them. Don't worry. That's why I have removed that previous bit. This bit is the list of all the connective tissue disorders that give rise to coagulation problems. But the great advantage is, by mercy of God, these are really, really rare. And if we start splitting the hair and going for the rarest of rare, then there will be no end to any discussion. And I am not a master of that. That's a hematologist's purview. So, we need to have medical history. If it is positive for bleeding, you check whether the patient is on certain medication. If the patient is on aspirin, NSAID, etc., go and manage as per evidence-based guidelines. Alright? This is positive, but the patient is on warfarin and newer anticoagulants, multi-specialty assessment and refer to specialist guidelines if required. These are the ones where you have to really modify. I'm talking about, just as I discussed, for heparinization and that kind of stuff. That comes in the second gray block. Now, if there is a big bleeding history, then go for either or both are positive. bleeding history and physical examination. You check. A patient comes with a lot of bruise anyway. So the physical examination tells you that this patient has a coagulation problem. Or there is a history that when I shave, I bleed for an hour if I get a small cut. So either of these two, check for all the coagulation parameters. There's a bleeding assessment tool, referral to appropriate specialist, as we discussed before. If it is a positive, it goes back on the previous block. All are negative, no further evaluation required, and you can go ahead. So, the first part is over. We're going for point number 4. Post CVS, coronary artery bypass graft. It is actually, in the ideal world, a successful CVS patient requires nothing else. It's supposed to be a normal patient. But it doesn't happen that way, because when we plumb two vessels together, the junction is a rough area. Not supposed to be, but it is. So, it's important to know time sense. As we discussed in the very beginning, 6 months, preferably don't touch the patient. Never ever think about a procedure under general anesthesia for these patients unless you are in a big team involving cardiologists and pretty high quality anesthesiologists. Still some antiplatelets will be there in CVD patients. Not supposed to be, but there will be. So you don't need it, but almost all patients of CVD will have antiplatelets and anticoagulants, about which we have already discussed. So these are the factors to keep in mind in a post-CVD patient and nothing else. Now the patient is on pacemaker. The other cardiac situation. I get many phone calls about patients with a pacemaker. So kept it here. Pacemaker should be understood in a group along with what is a block and what is an arrhythmia. Because these three together form the complex. All this time we are talking about the vascular activities going on in the heart. The blood vessels supplying the muscle, that's what we are talking about. Now we are talking about the electrical activity going in the heart. There are two functions that happen and the patients die or suffer due to two types of problems. One is due to the vascular problems, which goes in the line of MI, which goes in the direction of PTCA, CABG or actual cardiac death. And pacemaker is the other one, which actually handles the electrical derangements in the heart. I will talk in a line or two about blocks and arrhythmias in the next slide. So if the patient has a pacemaker, you need to know what is the status of the ECG of this patient. Don't have to read the ECG too much, but these are the factors that you should have in your, at the back of your mind. You don't have to go into all this. The patient will tell you that he has got major ECG problems. I will show you what we are talking about. You need to know the type of arrhythmias, what are blocks, what is Stokes-Adams syndrome. This Stokes-Adams syndrome, we all know, it is just an incomplete block getting complete. So there is a complete heart block. And when it happens, the exact point when an incomplete block moves into a complete heart block, the patient usually falls down, something like a syncope, and it's actually short-lived. However, the patient can move into a cardiac shock, and if a pacemaker, at least a temporary one, if it is not administered at that time, sometimes it could even be fatal. Stroke was the term, and stroke, which is a vascular event in the brain, they have a very similar thing, and there's a very small point, a few seconds, where the patient is just collapsing. That point, these confusing words come in. Just I mentioned about this word game because it is here when we are talking heart, we are limiting ourselves to Stokes-Adams syndrome, where the patient is missing a bit and falling down completely because there is no supply to the brain, not adequate supply to the brain. It is same in stroke, but absolutely different mechanism is happening up there. What is atrial fibrillation? It's a risky situation. We are talking about all the anti-platelets and anticoagulants. These AF patients are patients who are also on antiplatelets and anticoagulants as well. Pacemaker special issues you need to know. That's what you are waiting for. You just really don't want to know all this part of medicine you are waiting for. But what do we have to do with the patient with pacemaker? I will come to that. But it always feels nice if you have a good background. Again, antiplatelet anticoagulants coming, which I will not talk about because I have already done. And quality control of arrhythmia. This patient has got an arrhythmia. This patient will almost always have an arrhythmia unless it is aroused by a special technique inside the cardiac chambers, in the cardiac walls. Very few people get those things done. So many of them will. So this patient will remain in arrhythmia, but the patient will lead a reasonable life. There are ASA gradations. Everybody around us are not ASA 1. Most are using a few medicines and they are in ASA 2. Up to ASA 3 you are allowed to work on. So now this quality of control of arrhythmia becomes important. So after discussing all this, as I mentioned initially, you don't have to really find out from an ECG whether the patient has got a block. But why did I talk about this? Why did I talk about arrhythmia? Arrhythmia is important. Extremely important because you need to know arrhythmia, standard arrhythmia which is going on inside the heart of a patient and it is not bothering the patient. It should not bother you either. What should bother is symptomatic arrhythmia. Heart rate below 50 or 150 per minute. These are standard. This is actually a slide from ACLS protocol. Who are the patient who needs immediate attention or immediate referral? Heart rate below 50, above 150, patient is getting gradual hypotension, acutely altered mental status, talking funny, signs of shock, don't know that, issuing chest discomfort and acute heart failure. You'll find the ankle edema and facial edema as well. Can have a note of this only 6 points because we know the other side of cardiac disturbing patient who have got chest pain. That's one side of the story. This is the electrical disturbance of cardiac issues. This story is also equally important and should be remembered. So, just for interest, if you are still not bored completely, just for interest, first degree heart block is actually an increase. It's not very distinct change in the pattern of ECG. It is just the P wave, the PR interval. You know the PQRS. The P to R interval is more than 200 milliseconds, which is counted by the number of small blocks. So it is just a slower heart. In the ECG, it is otherwise normal, but a slower heart, not just bradycardia. Bradycardia is anything which is very similar, but it is not more than 200 milliseconds. The difference between bradycardia and first degree heart block is the distance between the P and QRS complex. Okay? 2-3 points of cardiac medicine. It will feel nice to know. Second degree heart block has got 2 types, Mobiles type 1 and 2. We are not getting into that. Very simply, if you look at it, you will see that the PQRS complex are going nicely over here. PQRS, it's not more than 200 milliseconds. PQRS, PQRS, PQRS. Where has this QRS gone? The missing QRS is a second degree heart block. Finally, you have got no relation of P and QRS in the last thing. There is one P here, the next P is here with a big distance, and then there is the QRS and an immediate P, that is not T. There is a P. The T is here. Then there is another P. No QRS in between. Then there is a QRS and a P and a T has got confused. So this is a complete heart block where there is no relationship that can be identified between the P and the QRS. So just notice 3 types. That PQRS standard sinus rhythm everybody knows. At third year, everybody knows what is the standard PQRS. Standard PQRS with a long block beyond 200 milliseconds is a first degree heart block. Let us not go into movies type 1 and 2. Simply some missing bits. More P's than Q's. More P's than Q's. You have a slice, count the P's, count the Q's. If P's are more than Q's, leave the last ones always. If P's are more than Q's, it's a second degree heart block. If you cannot find a distinct relationship between the P's and the QRS's, it's a complete heart block, third degree heart block. So, if you have an ECG, sometimes if you know that this is the patient of a block and the patient is carrying the ECG, don't just push over the file, just check. It feels nice. Medicine should be fun. Now, special issues. Again, don't read all this. As I mentioned, this is the official guideline of management of pacemakers on a dental chair. This is a Boston Scientific Analysis of Dental Equipment and Potential Interactions and with implantable pacemakers and defibrillators. So that's all, and that has been reduced to a simplified format. And even don't read the lines, just go for the points which are underlined. Detailed medical history, Specification of cardiac pacemaker, what type of cardiac pacemaker it is. That is important. The old-fashioned ones are arm insulated. So you ask for the time, I think I've mentioned somewhere which are the dates. 1990. Pacemakers before 1990 were of two types. They were either insulated or uninsulated. Beyond 1990, pacemakers are mostly all insulated, so you are in a safer zone. Given medical history, specific cardiac pacemaker, what are the medications? We have talked about it, why medications are important. Consider the use of hand scalers, although piezoelectric scalers are documented to be safe. But it's better to play even safer. And if there is a value of EMV, electromechanical value, something, EMV, it is written on all the machines, all the electric machines. If you go back in your clinic and you check all the machines that operate automatically, electrically, have got an EMV. If the EMV is below 37, it will be written there, they are supposed to be safe for all pacemakers. So you can have a note of what is the EMV of your scaler and keep it placed somewhere. 37 and below are safe. Patient should be motivated to use manual toothbrushes rather than the mechanical ones. Electrical cords over patient. We sometimes use plenty of electrical equipments and the cord sometimes lie on the chest. When electricity moves, if you remember the physics classes, though we are not using that degree of electricity, but there is an electric field around the wax. And the pacemaker is an electric element, it has got its own electric field. The problem with pacemaker and dentistry is that when we use some electrical equipment, the fields should not interact. That may cause, it is so serious, that issue, so casual but so serious. Why do we all switch off our mobile phones in airplane? It is almost that kind of magnitude. One mobile phone will probably never crash an aeroplane. Exactly like that, one scaler will probably, or a cord will probably never stop a pacemaker. But it is that kind of security margin that you are maintaining. So don't put an electric cord across the chest. Unshielded and shielded, we have already talked about. Electrosurgical units, if you are using the cauteries, use a bipolar, much safer, rather than a monopolar, because a straight current will actually interfere. And if at all you are using any communications, that means if the patient's body is used in the circuit, which happens in monopolars, use the other side, because electricity, whole parts of nature, like that is why we need so little medicine. Because we only like to do, nature likes to do the minimal that is necessary. So electricity will flow on the other side. You can think like the patient is the one. Patient has got the pacemaker placed on the left side or right side, whichever side. It's not necessary to place a pacemaker on the chest. Remember that. You will find plenty of pacemakers placed on the abdomen. On the abdominal wall, that is. So the patient is lying there, patient's body is using as a part of the circuit. Now, why is this person talking a foolish statement that go on the opposite side? That is because electricity is also lazy. It will follow the shortest path and it will completely bypass the pacemaker and move in that direction. So do not cross the pacemaker in a circuit when you are using an electrocautery, if you at all are. Symptoms of pacemaker malfunction you should know, and pacemaker malfunction. Now, here comes the point. Why I mentioned before, what is unstable or symptomatic arrhythmia. You will actually start seeing the features of symptomatic arrhythmia if the pacemaker is causing problem. Point 6. Rheumatic history. Favorite question in BDS, unfortunately sometimes in MDSs as well. Rheumatic history, rheumatic fever, rheumatic valve disease, and the antibiotic prophylaxis. You all remember that used to be a big nuisance. One question was always going to come from there. Things have changed. What is the law? I've already talked about the examiners. The protocols have changed. Remember that the protocols have changed. Prophylaxis against infective endocarditis. Official NHS nice guideline. Something which you can put up in any court of law anywhere in the world. Antibiotic prophylaxis against infective endocarditis is not recommended for people undergoing dental procedures. It's gone. I still know people who will deduct marks if somebody says that I would not give any antibiotic prophylaxis in extraction of a patient with no history of rheumatic fever. Very unfortunate, but fluorescein mouthwash should not be offered because that gives a false sense of security. It's nonsense. So we do not require prophylaxis for rheumatic conditions anymore. That is official. This is from public domain, issued as far back in March 2008. You can have this downloaded and keep it on one of the special folders in the desktop. God forbid, under any circumstance, under any question, you can put this out and they might file a case against NICE. Hypertension, commonest of cardiac conditions. Now, what's the problem if the patient has hypertension? That's the most important issue. Just because the patient is hypertensive, you don't start getting confused. You need to know how is the control. The patient has very poor hypertension, but fantastically controlled. This is a normal patient, isn't it? So you have to be very sure about that area. Now, when is it a problem? 200 milligram of mercury SBP or 110 milligram of mercury DBP are issues where you call this patient poorly or uncontrolled hypertensive. And poorly and uncontrolled hypertensive can be an issue. How do you handle it? You don't handle it. Patient's cardiologist handle it. This is the area where you make a knowledgeable referral. You write it on your prescription. This patient has got uncontrolled hypertension. This is the patient where he should come back to you controlled. Antihypertensives, you better have an idea about what are the common antihypertensives. They come in groups and you know the side effect of the groups because those can become important. Issue of stopping aspirin has been discussed. Second issue comes with these hypertensives is whether to use adrenaline or not. Alright, that's another point which comes in the practice and a question comes up. And there are funny people who even gives in writing, use local without adrenaline in these patients. Even today, with a date, with a registration number, they sign it. We all know this book, Medical Emergency in Dental Office, Stanley Malamet, 7th edition, page number 447. That's what it says. Clinical evidence dating to 1955 has accumulated supporting the statement that for most patients at cardiac risk, local anesthetic formulations containing a vasoconstrictor like epinephrine or whatever are indicated for pain control during dental treatment. The American Dental Association, in conjunction with the American Heart Association, officially recommended it in 1964. 1964. During period of stress, the problem comes, during period of stress, normal epinephrine released from the adrenal medulla can increase 20 to 40 fold. So, if you have given a patient less than optimum control of pain, by avoiding adrenaline, you have given the patient more adrenaline than what you can give through your local anesthetic injection. Okay? So there is no point. Don't argue. You can give a small sentence written somewhere that it is considered that without adrenaline the patient is at a higher cardiac risk. Okay?